يا باشا واحد خالص.
بسم الله الرحمن الرحيم. ان شاء الله نحن اليوم العيد النهارده المهندس الاستاذ الدكتور حسين شيشة. طبعا هو استاذ يعني غصب عن اي حد مولود استاذ. على الفارماكوجينيتكس او كوميونيسابيلتي. ماشي اتفضل.
بس الجو ده احسن مش بتاع بتاع النقط هي كثير وزي
اما هو
لا لذيذ على لا لذيذ.
بسم الله الرحمن الرحيم. طبعا في البدايه اسعدني ان اشكر الاستاذ دكتور مالك على دعوتي للمحاضره دي، وبشكر الاستاذ دكتور المهندس على الكلام الجميل وكل الناس يعني التحيه اللي قابلت بها. وطبعا لازم احط صوره الدكتور مالك كالعاده. ديت الصوره اللي اتاخدت في سبتمبر اللي فات لما كنت محاضره الكونسبرسيف الدكشن سيراميك في الكورس بتاع صور كلها. فده صوره الدكتور مالك في سبتمبر. ان شاء الله المره الجايه نحط صور من اخدها النهارده الدكتور مالك. ومتشكرين على دعوتك.
ربنا يخليك.
Focus of presentation طبعا pharmacogenetics means suppressive drugs is very and hard to cover. وانا عارف الناس اكيد عاوزين يتعشوا.
لسه واكلين مالكش دعوه.
So I try to simplify it as I can. So I have some slides for introduction. Then I'll discuss the pharmacogenetics and the calcineurin inhibitors, and then other immunosuppressive drugs, and finally the conclusion. So to start with, this is the journey of drug. So we have pharmacokinetics and the pharmacodynamics. All of us know pharmacokinetics means what the body behaves with the drug. So absorption, distribution, metabolism, and elimination are the main components of pharmacokinetics. Pharmacodynamics means what is the behavior of the drug with the body. So it is either effectiveness, efficacy, in the morning, give the presentation of pharmacodynamics and drug interactions. So if you look to this map, you can find a lot of issues. And the genetics and the genetic makeup of the patients make a role in regulation of pharmacokinetics and pharmacodynamics, as I mentioned later. I start with the Human Genome Project, which was completed in 2003. As you know, the genome includes 3 billion bases. The base is either purine or pyrimidine. Purines, adenine, guanine, pyrimidine, cytosine, and thymine. And each base is attached to phosphorus and sugar to form nucleotide. This is the language of the gene, the nucleotide. Each 3 nucleotides forms a codon, and the codon is specific for specific amino acids. So in our body, we have only 20 amino acids, but we have 60 codons. So amino acids can be expressed by 3 different codons. The people have 20 to 25,000 genes, but the exact number is not known. And the coding parts of the genes are only 1.5 of the genome. So not all the base pairs are expressive. We have exons and introns, and we have active genes and inactive genes. So personalized medicine, what's meant by personalized medicine? The personalized medicine means that there is a difference in reaction to the drug by different people. So this may lead to difference in the metabolism or excretions or pharmacodynamic, whatever, and this leads to development of pharmacogenetics and the pharmacogenomics. If there is a difference between pharmacogenetics and the pharmacogenomics, you can find in many literature they are used interchangeably, but there is academic difference. Pharmacogenetics means we are dealing with a specific gene, but pharmacogenomics, this is more broad because pharmacogenomics look at the wide association of the human genome. So if you have a person with abnormal response to the drug, and you have other who is not, if you look at the sequence of the genes in this person versus other person, this is in a case control, you can find by sequencing the genes and by genetic study what are the abnormal genes in this person. So this is the pharmacogenomics. When you put your hand on the specific gene, this is pharmacogenetics. But you can use this for that. So pharmacogenomics is the study of the role of inherited and acquired genetic variation in drug response. To start with the pharmacogenetics and immune suppressive drugs, I should mention what's meant by single nucleotide polymorphism. Why I am stressing on this variance of the genes? Because it constitutes 90% of all genetic variations. The other are tandem repeats and restriction fragment length polymorphism. So I mentioned before nucleotides mean base, sugar, phosphate. So if you have two alleles, allele means different form from the gene. If you look to the sequence of bases here, the first row is identical to the second one, except G guanine is changed to thymine. So this is just single nucleotide change. So the question, what's the difference between single nucleotide polymorphism and the mutation? Single nucleotide polymorphism principally is above 1%. You can find single nucleotide polymorphism in 50%, 60%. Sometimes in certain races you can find the majority are polymorphism. So the mutation should be less than 1%. Is the difference just in the percentage? No. If the mutation is present, we will find phenotypic abnormality in the person. But in the presence of single nucleotide polymorphism, we will not find any abnormalities except in certain circumstances. So if the single nucleotide polymorphism is specific to the drug, you will not find this abnormality except if the person is exposed to drug. So this is the difference between single nucleotide polymorphism and the mutation. I think the Professor Adel Bakr mentioned this statement, does one immunosuppressive regimen fit all patients? And he answered no, and I agree with him totally. And this may be to the different genetic makeup of the patients. If we start the journey of the immunosuppressive pharmacogenetics, we can start from the first date of transplantation in December 15, 1954, when Joseph Doré allocated the first transplantation at Brigham and Women's Hospital at Harvard. At that time, the second of the immunosuppressive drugs and the immunological workup are very primitive and in their infancy. So what is the success, the secret of success of the first transplantation? It depends on twins, identical twins. To know that they are identical twins, Professor Morin exposed hairy twins to fingerprint examination to be sure that they are identical twins and not fraternal twins. As you see in this table, we find a lot of genotypes for the current used immunosuppressive drug, and I mentioned them one by one. So let us look at this table, at this figure. This is the Tacrolimus-Lim level. All these dosages achieve the same level. But look here, the dose here is very small. Here is very big. Here less than 0.04 milligram per kg, and here reaching 0.4 milligram per kg. So although there is a big variation in the dosage, the level is the same. This means that the peoples are different in response, and the level is different from person to person. Why? One of the reasons is the presence of ABCB genetic polymorphism. What is ABCB gene? The other name is multi-drug resistant gene that codes for the transporters P-glycoproteins. The protein encoded by this gene is an ATP, dependent drug efflux pump. So, just to show this, the value of this P-glycoprotein, if you look to this figure, if the patient is CC genotype, the expression of P-glycoprotein is very abundant and the pump is very active. What will happen? The pump leads to influx of the drug into the intestinal lumen, leading to decreasing absorption. So patient with CC genotype, the absorption capacity is low. If the genotype is CT, the activity of the pump is midway, so the absorption is midway. If the genotype is TT, the activity of the pump is very low. What does it mean? The absorption threshold is low, and the absorption is maximum. So if we wanted to achieve same level for these three patients, this patient will need big dose, and this patient will need a small dose. If you use the big dose for this patient, you will introduce toxicity. So there are ongoing studies nowadays to know the genotype of the recipient before transplantation. And if you know that you are dealing with a patient TT, you can give him a small dose at the start. And if he is in the CC genotype, you can give a broader dose from the start. It is not only recipient genotype, but also the donor genotype affects the absorption and the pharmacogenetics. If we look here, this is ABCB genetic polymorphism of recipient, and this is of the donor. So whenever you find a combination TT, this means the pump is very low and the absorption is maximum, and the donor is the same, you can find here significant higher level. So if you have recipient and donor sharing in this polymorphism, you will need very low dose. If the genotype of the recipient is fixed to CC, means the pump is very active, the genotype of the recipient doesn't make sense, no difference. If it is midway, the presence of, if the recipient is CT, means the activity of the pump is midway. If the donor is TT, the absorption is increased, enhanced. The same here. Another point is haplotype. What is the definition of haplotype? We can imagine that haplotype means that we are getting one total chromosome from certain parents. No, the definition, the academic definition of haplotype is a cocktail of different alleles. So we have here three alleles, different forms of the genes are inherited together because they are close to each other in the human genome. And this is if you apply this definition HLA, you will find HLA haplotype because HLA, B, C, and DR lie in the short arm of chromosome 6, lying together. So if the recipient, if the donor carries this variance, you can find difference in the level, the same for the recipient. Another important point and application for the pump, Tacrolimus-Lim, that was announced 3 years later in the ACT, they added Lim to Tacrolimus. This is another drug. The function of this drug is to enhance the pump system in the kidney and the pancreas. Because P-glycoprotein is expressed, yes, in the intestine, but also can be expressed everywhere, so it can affect distribution. If the side effect of tacrolimus is principally on the kidney, nephrotoxicity, and on pancreas diabetes, and you give the patient Lim plus tacrolimus, you will have the effect of tacrolimus in the immune system, but you will you increase the efflux of this drug from the kidney and the pancreas, so you decrease the side effects of the drug. So this is a rat model This tacrolimus-Lim confined here extensive vacuolization with addition of the Lim no vacuolization. And this is the tac exposure at 30 minutes post dosing. You can find here very minimal in the Lim arm. And I think there is ongoing innovations and improvement and of this system. It is not only pharmacogenetic, but also ABCD can predict the outcome. So certain genotype may predict, ABCD genotype may predict the outcome, delay graft function, and even the occurrence of cytomegalovirus, as you see here. If the exon 12 CT and TT genotypes are linked with cytomegalovirus. This is the largest pharmacogenetics and pharmacogenomics study to the date because it comprised 4,400 or more donors and recipients. All of them were exposed to genetic studies for 52 or more genetic polymorphisms. They started with discovery cohort from Birmingham, UK, and they found that the CC genotype is linked to poor graft survival. The same is confirmed in Belfast cohort. CC genotype carries the lowest graft survival. And in CTS study, including approximately 3,000 cases, you'll find here CC, and especially tacrolimus, linked with poor graft survival. So it is not only the dosage, but also is the genetic polymorphism that be associated with outcome. Regarding cytochrome system, there are many variants and forms of cytochrome, but the most important two types which are linked to immune suppressive drugs are 3A5, which is linked to tacrolimus metabolism, 3A4 for cyclospore. Kid resident with cytochrome P3A5 star 1 polymorphism declared tacrolimus at rate 25 to 45% greater than the star 3 patients. So if I know the genetic makeup of the patient regarding cytochrome system, I can expect this patient expressor, this means a fast metabolizer, or non-expressors means slow metabolizer, and this will change my prescription to the drug. Here, this is an example of the polymorphism. As you see, there is a difference of the percentage of expressor and non-expressor according to race. If you look to the white one, which is non-expressor, you can find here the list is in the blacks, so the blacks are mostly metabolizers and fast metabolizer in comparison to Caucasian and South Asian. The same, if you are dealing with fast metabolizer, you can find the level is low. And again, if you apply the same to once daily or twice daily tacrolimus, you can find here. And if you are dealing with fast metabolizers or expressor, you need big dose, 10 mg per kg versus 6 mg per kg. And I think we have no time to explain all this table. It is not only just the metabolizer and dose, but here in this fascinating review of the CNI Nephrotoxicity, you can find the local exposure of the genetics can explain calcium inhibitor nephrotoxicity. Even in hemolytic stem cell transplantation, if both the donor and recipients are non-CC, as you see here, the creatinine is preserved. Survival, transplant-related mortality are in nadir or the least percentage of the genotype of the both donor and recipient is non-CC. The same here, non-CC survival is better, so it is also outcome. This is another haplotype effect because this haplotype is controlling the release of pregnein, which is detoxifying agent. If there is a variant, it is linked to the virus, so it is also another outcome. Regarding the anti-proliferative and inhibitory inhibitors, there are UGT polymorphism, which is UDP glucosyl transferase, which affects the pharmacogenetics of MMF, and another genotype can explain the presence of anemia or lipopenia in certain patients after MMF. Regarding the genetic polymorphism in the enzyme thiopurine, S-methyltransferase is very important because it's announced even in the level of PDF of the FDA. This enzyme is a rate-limiting step in the metabolism of azathioprine. Azathioprine is changed to the active drug because it's pro-drug to 6-methylpurine, which is metabolized through this enzyme. So if there is variations in this enzyme, the patient may be in circumventing toxicity of azathioprine if you give him big dose. The same here is that sinusoidase enzyme lead to inactivation of 6-methylpurine, and this is the secret. If you give allopurinol, you will increase the toxicity of azathioprine. The reaction of cytochrome P-system with sirolimus, here you can find the expressor, the level is low, the same, either you are dealing with all patients or Caucasian patients, but there was no significant influence of cytochrome genotype on the pharmacogenetic of everolimus in this study. This is the effect of genetics on pharmacodynamics. Here you can explain this lipidemia associated with sirolimus. If the patient carries this ABCB genetic polymorphism, you can find total cholesterol is very high, either without or with prednisolone and even the level. So it can also explain the pharmacodynamics, which is the lipidemia, side effects from sirolimus. I want to emphasize that it's the pharmacogenetics with the interactions and suppression is an ending stage. If you look here, there is polymorphism in cytokines, interleukins, and here there is a star labeled interleukin 4R and 6 are the genotype of the donor. You can find here all these genetic polymorphisms are associated with either rejection or graft failure. The same here for chemokines and adhesion molecules, so it is very interesting as I mentioned. I want to conclude this presentation by this quotation. As all is stated, I love doctors and they hate their medicine. And this person, Paracelsus, mentioned poison is in everything, and nothing is without poison. Drug is poison if we infuse it without the knowledge sufficient to practicing safe medicine. So the dosage makes it either a poison or a remedy. To know the proper dose for certain patients, we should know everything about the drugs and pharmacogenetics. And today I added the pharmacogenetics of patients. And if we know well the pharmacogenetics, we are dealing with an art of medicine, as Sir William Osler mentioned. If it were not for the variability among individuals, medicine might as well be a science and not an art. With personalized medicine, we search for formulas that help us decide which is perfect treatment in drug and dose for each patient. Pharmacogenetics had the potential to complement therapeutic drug monitoring, so drug monitoring is not enough for all patients. But the most important questions, are we ready now for the prime time? All of you will say no, we are not ready. And the main obstacle for pharmacogenetics is the availability, the cost, and as you see, inconsistency of the results and the redundancy of all the genetic background, receiver and donor. But with gene-based clinical studies in place, we can expect to have clearer understanding of the merits of pharmacogenomics in everyday clinical practice. And I think this is the bus. كان في رحلة سيوة الأسبوع اللي فات الساعة 5:30 الصبح، الجو كان الحرارة تقريبا ناقص 2 ولا حاجة زي كده، وقبل سيوة 150 كيلو، الأتوبيس توقف ليه؟ قال لك الجاز اللي فيه بقى سوليد. فعلشان الراجل ده يشغل الباص حط ولع تحت الاتوبيس. صحيح؟ في الاتوبيس يا راجل. صحيح. لا صحيح احنا الاتوبيس اتحرك هنا ووصلنا، بس ما اعتقدش ان ده السيف واي ان احنا نديله immune suppression. Immune suppressions are not without toxicity, and I think rich يعني واحد دريمينج ان احنا نوصل لحاجه نعمل بها تنبوش الاميون سيستم ونعمل ريدوس ان نديها للبيشنتس. اذا كان الفارماكوجينيتكس هنحل القصه دي يبقى مرحبا بك. شكرا لحسن الاستماع.
Thank you. part of the sirolimus or the intracellular. Sometimes you will find the patient with low level, low plasma level between CNI and CNI system, and another patient with high level CNI with rejection, not related maximally to the plasma level but related to the intracellular level.
ده سؤال جميل جدا لسبب واحد لغايه دلوقتي ما حدش يقدر يجاوب عليه. الحاجه الثانيه اذا كانت القصه مش في الليفل ده بيعكس الابسوربشن، يعني ده بيعكس البايو افيلابيلتي، يعني الدرجه المتصل منه قد ايه وصل للستيم سيركيوليشن. لكن اللي حضرتك بتقوله ده فارماكودايناميك. انا عندي ليفل قليل بس راح عمل مشكله كبيره، فده فارماكودايناميك احتمال لو درس. هو بيجي يعمل ايه؟ بيشوف شخص زي ده عنده ليفل قليل وتوكسيستي، وشخص ده عنده ليفل قليل وريجكشن. تمام؟ لو الجينيتك
السيكونسنج درست الاثنين ممكن انا احط ايدي على حاجه لو كان الجينيتكس لابد. يعني ده وده كيس كنترول ستاتيفيكيشن. لكن هل حد عمل الكلام ده؟ ما حدش يعرف.
هو الفيوتشر في الفارماكو not the pharmacogenomics. Yes, the pharmacogenomics. Everyone is going to have a chip with these things to tell ده ما ياخدش أمثلة مش هتنفع معاه. ده ما ياخدش Tacrolimus، ما ياخدش CNI. اللي هو اللي بتقوله الدكتور حسين أو الدكتور ياسر الليفلز مش عالية وحصل له أو الليفلز مظبوطة وحصل له ريجكشن. That's why this is going to be in the future.
وعلى فكره بقى لغايه مثلا في الوارفرين بقى في كلام كتير عن القصه دي ويبقى مهم.
طبعا اشكرك كثير على الاكسلنت برزنتيشن كالعاده. هو يو هايلايتد حته بس عدتها بسرعه. انا بالنسبه لي امبورتنت الدكتور ياسر والدكتور طارق يعني بوم اباوت الفكره ان الليفل زي ما حضرتك بتقول الفارماكوجينetics of the drug. These are the genomics of the recipient. انما التيشو افكت are the pharmacogenomics of the donor. الاورجان اللي بيشتغل الريسبتور اللي عليه بالافيلابيلتي of the receptor of that drug is related to the genomics of the donor. فبالتالي you need two ships of the donor.
هو تعرض لكده والدكتور ماهر كنا مستغربين. هو بيتكلم على الدونر بوليمورفيزم.
ايوه ده فيري امبورتنت.
القصه الاسلام الكبيره اللي عطانا 4447 ده دونر وريسيبيانت. بس كان الامباكت اللي طالع كان البوليمورفيزم بتاع الدونر مش بقى على الابسوربشن، لا على الاوتبوت جرافت فيلير.
efficiency يعني ممكن واحد هاي ليفل ويجي له ريجكشن، واحد هاي ليفل ويجي له توكسيستي.
بس هو لغايه دلوقتي ما نشروش هذا الكلام، يعني ما حدش قال التفسير.
لا في ناس اتكلموا عليها،
في ناس اتكلموا في ناس بيتكلموا اعمل جينوتايب او اعمل اتش ال اي ودار للريسيبيان والدونر، اعمل الاثنين واشوف واختار الدرعه اللي تتماشى مع
يعني اقول لك هو التوتال ليفر بتسد البان فيها بقى لما تشيل الاورجان كله وتحط اورجان تاني. بقى مهم الدونر هنا ان انت لازم تشوف هومولوزايجوس ولا لا للسيتوكروم بي. لكن لو هو كدني الامور مش هتبان، هتبان في الليفر تماما. وعشان كده الجينوتايبنج للدونر هو اهم من الريسيبر. الريسيبر مش مهم خالص.
ويمكن الاي بي سي بي جين هيبقى مهم في الكيدني او نفس
في فابريكيشنز فعلا على الكلام ده. مش في فابريكيشنز على
ده بتبعت في Pharmacogenetics
البرزنتيشن هاي كالعاده. بس انت لفتت النظر كمان لذيذ ايشو. يعني الجيناتكس دايما الحقيقه الواحد بيشوفها انها كبيره قوي، بس القصه لو الواحد دخل الدرس مش not so expensive زي ما احنا متخيلين. يعني just the private لو واحده اتجاب خلاص الدنيا بتبقى not costly. والنقطه اللي انت بتقولها الجين associated clinical trials الحقيقه احنا بنصرف قد كده في drugs waste of drugs في immunosuppressant very expensive. فلا يعني في وسط الناس الحلوه القاعده دي نريز الايشو ان دايركت كلينيكال ترايلز اللي هي جين اسوشيتد، عشان احنا مش مدروسين. يعني حضرتك تقدر تجيب الجينوتايب بتاع الاوروبيان والاناماتوكيزيان واحنا مش مدروسين خالص. فالحقيقه الشركات ضروري ينفون ده. النقطه الثانيه ان في فاندنج بوديز كتيره جدا بتابريشيت وبتساعد ديز كلينيكال ترايل، جين اسوشيتد كلينيكال ترايل. يعني لو قعدت حضرتك بصيت على clinicaltrial.org هتلاقي كتير جدا فاندنج بوديز فور ذيس. فلاتس يعني ما نبقاش يعني نطلع بتوصيه لاتس في الميتنج ده ان احنا ننكرج ذيس تصدي منصور.
موافق على التوصيه.
لا كلام جميل جدا.
وما كان
انا مش بعمل
خلاص
فيري نايس ليكشر وفيري موسكو الناس كلها حلوه.
مثلا سؤال نايف انا ما فهمتش. Do we have any real application of what we have already said, either on a clinical thing or even on research? يعني أكمل كلامي بس. معلش شوية.
مش انت بتجيلك ناس مثلا بتاخد مثلا في دوزز بروجراف مثلا،
لا انا مش قصدي
والليفل بتاعها واطي قوي بتضطر
لا
او العكس.
we have a knowledge, some knowledge, our genome, whatever.
still knowledge.
Still knowledge. Even in US or whatever, they don't use it. Even in daily practice, you will have genomic.
As I mentioned, there is ongoing studies to determine MCP to calculate the dose from the beginning to give big dose or low dose, but still there is no application.
There is to convince my data to use this knowledge in the practice until now.
حضرتك دكتور احمد معلش ردا على الموضوع توصل احيانا اضطريت احجز عيان تخصصي عشان بياخد 9 اقراص مرتين في اليوم
الليفل بتاعه
لا انا هديك مثال بس. واحد قال لي مثلا بيجي ورايا بياخد مثلا 1 مللي جرام في اليوم عشان ادعي كده
كان في أمراض كان في أمراض، لكن حاليا الأمراض بتاعتنا في كونسنس
يسأل عليه. الحقيقة احنا يعني الصالح كان حالة كونجونيت سيركيوليشن بين جامعة اسكندرية وبين الجيش الدكتور خالد عويضة، وكان فاميلي الحقيقة عندهم chronic kidney disease و two of them one reached chronic renal failure وواحد كان nephrotic و chronic kidney disease، والحقيقة عندهم كمان Addison disease and one of them عنده Addison disease. We investigated this family مع الكوبريشن بتوع معهد الباثوجينetics، طلع عندهم endocrine dysplasia الفاميلي دي كلها. والحقيقه لقينا معاونات من اماكن كثيره جدا عاوزين تنفستيجيت these cases يعني. وكان السؤال ان ما عندهمش غير من الفاميلي. كان السؤال المحير البنت دي تزرع تدي لاخوها ولا لا؟ يعني كان هو فالحقيقه يعني مفيش ابلكيشن، يعني مش
ابلكيشن ان شاء الله. انا معلش هقولها بالبلدي، يعني انا هعمل جينوميك بروجكت للعيان ده واقول ده ياخد كذا وكذا وكذا والليفل بتاعه كذا، لغايه دلوقتي مش معروف.
الجينوميك ستادز ليها ليميتد ابلكيشنز انكلودنج البارامترز بس، وفي الماريفان
موفرين هو الوحيد موفرين اللي هو الانسان بتاع الامبراطوري
ولا ابتدى يبقى
هو بص لما تدخل في العيان بقى سامع عيان عندك عيان بتديله بقى ادويه كتير وتاكرولومس-ليم سنه 9 و9
احنا كنا من غير الصدى في المنصورات اللي بياخد محتاج ساعات كروز بنحجزه فعلا ونشوف دار بس ايه وبعد كده هو
الكيتوكونازول اتمنع عليه حاجات ثانيه كتير. الكيتوكونازول اتمنع عليه
حاجات ثانيه اقل
لا حاجات معاه
الكيتوكونازول اتمنع عليه.
مش عارف والله
لا ده بيعمل طلع له توكسيستي وحاجات كارسينوجينيك ساعات او حاجه كده. لا يعني اقصد ان هو وقت لا عشان
كده لسه بدأنا يا باشا ده كلام كده هنخلص بدري كده بس يلا نجري انا مش هديها مش هدي حضرتك انا مضغط
كان مستريح زي مرسل بالظبط
في 10